Go on Chapter 2, Patterns of Disease Occurrence. Section 3, How to describe the patterns of disease occurrence in population. First, look at patient profile. A 34-year-old female domestic worker who had recently emigrated from Southeast Asia to the United States came to the emergency room with a 6-week history of cough, fever, night sweats, weakness, fatigue, and shortness of breath. The patient was diagnosed with tuberculosis, though chest X-ray and a smear of a sputum specimen. The patient resided with her husband and 2 young children in an apartment building. Tuberculin skin tests were administered to each of the family members at the time of the patient's initial diagnosis, and the results were positive for the patient's husband and 3-year-old daughter. Clinical background. Tuberculosis is caused by mycobacteria transmitted on small airborne particles that are created when an individual with pulmonary tuberculosis coughs or sneezes. Air currents circulate these particles throughout an entire room or building. When a susceptible person inhales these particles, tubercle bacilli may become established in the lungs and spread throughout the body. How to describe the pattern or distribution of tuberculosis within a population? The pattern or distribution of tuberculosis within a population can be characterized by 3 basic questions, 3W. Who develops tuberculosis? Where does tuberculosis occur? When does tuberculosis occur? Answers to these questions characterize the distribution of tuberculosis by person, by place, and by time. Descriptive studies can be used to describe the pattern or distribution of tuberculosis, including activities related to characterizing the distribution of diseases in a population. The tools for descriptive studies are measures of disease occurrence, such as incidence rate, prevalence rate, mortality rate, and case fatality rate, etc. Let's review epidemiological approaches. According to the purpose of the research, there are 2 types of epidemiological study design. One is descriptive studies, another is analytic studies. Descriptive studies concentrate on the description of distribution of morbidity or mortality by person, by place, and by time. Several types of studies are in this category, such as case report, case series, ecological study, and prevalence survey, or cross-sectional study. The information obtained by these descriptive studies is not only useful in health care planning, but also can provide clues to the potential causes of diseases. Analytic studies are more concerned with the relationship between the exposures and the outcomes. Common designs are cohort study, case control study, and experimental study. Generally, 1 or more hypotheses are generated based on the information from descriptive studies, and then tested to help identify the potential causes of the morbidity or mortality. How to describe the disease in the population? By person, means population distribution. By time means time distribution. By place means regional distribution. Then, comprehensive description of the distribution of disease of crowd, area, and time is by migrant. By this description, we may have the idea of disease in the population, and furthermore, it is possible to explore or find the potential causes of the disease distribution. Distribution of disease by person. Age, sex, risk group, education, occupation, socioeconomic status, marital status, immunization status, and some lifestyle or behavior habits are common variables used to describe the distribution of disease. For example, we might describe the distribution of coronary heart disease in one community by sex, age, occupation, and some lifestyle factors such as smoking, drinking, and physical exercise. These descriptions may give us a very good idea of this disease. This data will be very useful for the estimate the burden of the disease and policy making. These descriptions may also provide us some thinking of who are in the risk group and what is the potential reasons of the disease. Age. There is the closest relationship between age and diseases. The increases in disease, morbidity, and mortality with age are more apparent than for any other variable. Increase with age, almost the majority of diseases are a significant change in the frequency. The effects of age are often ascribed to an individual's cumulative exposure to environmental results, such as chemical, social, cultural, or lifestyle exposure, over a lifespan, or to be the effects of physiological factors. As with breast figure 1 is 4 groups of different populations. Age distribution of female breast cancer. The epicenter is age. The ordinate is incidence rate of breast cancer per 10,000 women. The 4 curves show that the incidence rate of breast cancer increased with age in 1970s last century, especially after 30 years old. In the 4 regions, the incidence rate of breast cancer in white women in the Gulf of San Francisco was the highest, and the lowest in Japanese women. Figure 2 is distribution of age, deaths, and the numbers of deaths in the world in 2004. In the area map, half of all deaths occurred in people aged 60 and over, followed by those aged 15 to 59. Figure 3 is age-specific mortality of tuberculosis in Massachusetts state men in 1880, 1910, and 1930. The epicenter is age. The ordinate is mortality of tuberculosis. 3 curves show 3 cross-sectional analyses, all description about the association between age and mortality rate of tuberculosis in 1880, 1910, and 1930. And another description about age distribution of tuberculosis is birth cohort analysis. Figure 4 is age-specific mortality rates of males tuberculosis born in 1870 to 1910 in Massachusetts state. 5 birth cohort curves in 1870, 1880, 1890, 1900, and 1910 showed the changes in tuberculosis mortality with age and not affected by environmental factors. Table 1 is Massachusetts state men's age-specific tuberculosis death rate in 1880, 1890, 1900, 1910, 1920, and 1930 in different age groups. There are 6 cross-sectional investigations, once every 10 years. The right number means birth cohort analysis of age-specific tuberculosis death rate, means the changes in tuberculosis death rate with age in a group of people with the same birth time. Birth cohort analysis can reflect the relationship between age and disease more accurately than cross-sectional analysis, because birth cohort analysis is not affected by environmental factors. Sex. Males have higher rates of disease and death than females for a wide range of conditions. For some diseases, genetic, hormonal, anatomic, or other inherent differences between the sexes affect their susceptibility or physiologic responses, such as premenopausal women have a lower risk of heart disease than men of the same age, a difference that is possibly due to their higher estrogen levels. The sex-related differences in the occurrence of many diseases reflect differences in opportunity or levels of exposure. Figure 5 is distribution of deaths by leading cause groups, including males and females in the world in 2004. The dark blue is male, the light blue is female. The death rate of cardiovascular disease in females is higher than that in males. The death rate of unintentional injuries in males is higher than that in females. Figure 6 is China's mortality rate for men and women of different age groups in 2003. There is higher mortality rate in men than in women. Figure 7 is China's cumulative reported HIV infections by sex distribution during 1985 to 2001. Male accounted for 81.6%. Females accounted for 16.9%. Social class, an important but imprecise term for a whole host of factors such as income, education, occupation, living conditions, and access to services. The frequency of many adverse health conditions increases with decreasing socioeconomic status, such as tuberculosis. Some adverse health conditions are more frequent among persons of higher socioeconomic status, such as breast cancer, tennis elbow. Differences in exposure likely account for at least some of the differences in the frequency of these conditions, such as occupational exposure. Some occupational harmful factors can cause occupational diseases. Figure 8 is present distribution of the reported symptomatic HIV cases by occupation during 1984 to 2004. The most common occupation is general hiring. Different ethnic and racial groups have different genetic predisposition, different customs, lifestyle and diet, different socio-economic status, level of health care, different settlements, natural and social environment. Different religions have their own independent doctrines. Canon has also influenced their way of life and the occurrence and the distribution of diseases. Figure 9 is United States of different racial incidents of hepatitis B during 1990 to 2001. The abscissor is years. The ordinate is incidence rate. The yellow curve represented the blacks of non-Hispanic. The highest the incidence rate of hepatitis B. The pink curve represented the whites of non-Hispanic. The lowest the incidence rate of hepatitis B. The customs and habits of different ethnic and racial groups can lead to different diseases. Figure 10 is the United States of different races, the incidence of malignant tumors of different gender. The above is the incidence rate of malignant tumors in different racial male groups. The below is the incidence rate of malignant tumors in different racial female group. Status and family. Often, there are major differences in disease rates according to marital status. Married persons generally have lower death rates than single persons. Some diseases have family aggregation. Family harmony contributes to physical and mental health. Lifestyle is an important factor affecting health. Many bad lifestyles or behaviors, such as smoking, drinking, drug use, improper sexual activity, less movement, and infatuation with access to the internet, can lead to the occurrence of many diseases. Distribution of disease by time. By time refers to the distribution of given disease by hours, days, weeks, months, years, or even by decades. From the description, it will reveal the temporal patterns of the disease. We might know the trend of the disease or some change that is unexpected. Common temporal patterns of morbidity and mortality include short-term fluctuation, cyclic change, seasonal variation, and secular trends. Short-term fluctuation refers to relatively brief, unexpected increases in the frequency of a particular disease. The occurrence of disease are associated with acute epidemics or outbreaks. There's difference between outbreak and short-term fluctuation. Outbreak usually in small crowd of people. Short-term fluctuation usually in larger number of populations, such as the outbreak of hepatitis A in Shanghai in 1988. Cyclic trend represent periodic increase in frequency of a particular disease morbidity or mortality. It often is predictable. Cyclic trend refers to changes in the pattern of disease which are recurrent. It is related to the number of susceptible persons in a population. Certain disease occurs with a typical periodicity. For example, a septic meningitis peaks yearly. Figure 11 is the incidence of epidemic cerebrospinal meningitis in Baoding during 1950 to 1988. The epicenter is years. The ordinate is incidence rate. There were periodic change in the incidence of epidemic cerebrospinal meningitis every 10 years before 1980s last century, and the cyclic trend was interrupted by immunization after 1980s last century. Seasonal variation. Often, there is a seasonal pattern to the temporal variation. Diarrheal disease is most common during the summer, and respiratory disease is most common during the winter. Seasonal variation is a kind of cyclic trend. Effective preventive measures can change the loss of the cyclic nature of the disease. This is the distribution of diarrhea caused by E. coli O157H7 in Indiana in 2000. The epicenter is mass. The ordinate is the number of reported cases. Diarrhea occurred frequently in June, July, August, September, and October. That is, occurred frequently in summer and autumn every year. This is seasonal variation, a kind of cyclic trend. Figure 13 is the monthly distribution of incidence of myocardial infarction in Beijing. The epicenter is mass. The ordinate is the number of myocardial infarction patients. Myocardial infarction occurred frequently in winter and spring, cold season. This is seasonal variation. Trend refers to the long-term pattern of disease in a population over a long period of time, such as many years, decades, or even centuries. The dynamics of the disease is observed for several years or even decades to observe the changes of pathogens, clinical manifestations, morbidity, and mortality of the disease, all their accompanying changes. Figure 14 is United States secular trend in several diseases during 1900 to 1973. During the past 70 years, the death percentage of 11 major infectious diseases had been decreasing. The death percentage of 3 major chronic non-infectious diseases, including heart disease, malignant tumor, and stroke, have been increasing. This is long-term change over 70 years, also called secular trend. Figure 15 is the tobacco consumption, lung cancer mortality, changes in male and female in the United States during 1900 to 1999. There was same trends between the number of tobacco consumption and the mortality of lung cancer in male and female, especially in male, during 100 years. Maybe there is association between tobacco consumption and death from lung cancer. Maybe tobacco is cause of lung cancer. Distribution of diseases by place. Place variables include various geographic characteristics. They might be based on administrative areas, such as countries, provinces, cities, towns, or neighborhoods, or might be based on specific geographic characteristics, such as urban and rural areas, mountainous area and plain district, or in different latitude or altitude. This is punctuation or spotted map by John Snow to describe the distribution of deaths from cholera in London in 1854. According to this spotted map, John Snow found all patients had the same water supply. So he concluded the cause of cholera epidemic was polluted water. This is regional distribution of malaria in 2003. This is the distribution of cholera in different countries during 2002 and 2003. Figure 16 is regional distribution of coronavirus disease 2019 in different countries on March 9, 2020. Figure 17 is adult mortality rates by major cause group and region in 2004. Distribution of disease in different areas of the same country in China. Schistosomiasis is limited in some provinces in the south. HIV infection more in Yunnan province. Nasopharyngeal carcinoma in Guangdong. Esophageal cancer in Henan. Liver cancer in Qidong, Jiangsu. Hypertension in north, modern south. Figure 18 is China's cumulative reported HIV infection distribution by provinces during 1985 to 2001, most in Yunnan and Xinjiang, middle in Liaoning. There's difference between urban and rural. In urban, more population density, more population mobility, more respiratory tract infectious disease, more chronic disease and cancer, and more occupational injury occurs. In rural, low population density, less population mobility, more intestinal infectious diseases, more insect intermediary infectious disease, and more endemic diseases. What's endemic disease? The usual presence of a disease in the human population in a given geographic area. This is often referred to as the endemic level or prevalence. Present in a community at all times but in relatively low frequency. Something that is endemic is typically restricted or peculiar to a locality or region, such as malaria, endemic goiter, endemic fluorosis, Kestenbach disease. Look at the picture. Endemic diseases such as endemic goiter, endemic fluorosis, and Kestenbach disease, etc. It is common in remote areas. There are 4 criteria of endemic diseases. First, incidence of the disease in any ethnic may increase in the residents in the area. Second, similar residents lived in other areas have the lower incidence or even not occur the disease. Third, who immigrate the area over a period of time, its incidence approaches that in local population. The people emigrate the area, the incidence would reduce or symptoms alleviate or self-healing. Fourth, in addition, the local animals are also susceptible to the same disease. Comprehensive description of the distribution of disease of crowd, area, and time is by migrant. By comparing populations of similar genetic background that are living in different physical and social environments, migrant studies can provide useful insights into the relative importance of environment and genetics in disease etiology. The basis of comparison is usually the rate of disease in migrants, RM, versus that of the population from which they originated, RO, or between the rates in migrants versus those of residents of the new host country in which they have settled, that is, RM versus RH. If RM is close to RO and different from RH, we may conclude that genetic factors contribute most to disease etiology. Otherwise, environmental factors may appear to play an important role for the disease.